My name is Carl Leroux. I work as a clinician scientist, and we certainly also have Kelvin Higa and Lee Kaplan together with myself. That's going to stir up some controversy and some discussion. And this is a session that's really here for your benefit. And for my benefit, because I want to learn from this experience, because we're going to put just 2 cases up that I think is going to stimulate some discussion about the challenges that you and I face on a day-to-day basis. So I see patients in clinic who've had bariatric surgery. I see people with medication. I see people with diet approaches. I'm an internal medicine doctor. And I also do all these interventions on rodents to understand the physiology. But I start with this slide showing you the Hans Christian Andersen tale of the emperor walking in front in a big parade. And of course, the emperor's tailors told the emperor that he was wearing these beautiful clothes, and that only if you are very intelligent will you be able to see the clothes. And of course, the emperor didn't want to show anybody that he wasn't intelligent, so he was walking down the road without any clothes. But it was only this little boy in the background here that raised his hand and said, "Is the emperor really wearing new clothes?" And so I would like you to be this little boy in the background today and actually ask the questions, of ourselves, and ask the questions of the experts on the panel, what we are doing, is that really the best that we should do? Or is there anything else that we can do better? I'm going to ask both Kelvin and Lee to introduce themselves in a moment, but I'm just going to introduce, some of the disclaimers. Of course, this is a meeting that is sponsored by J&J. And these are my own disclosures, and of course I work with multiple companies because I don't think that obesity is one disease. I think what we are treating are a combination of many, many diseases that just happen to result in excess adipose tissue. But what we have learned from bariatric surgery is that certain interventions such as bypass, sleeve gastrectomy, one anastomosis bypass, and others are very effective at treating many people. But what we have seen from the Swedish obese subject study, and this we are very fortunate to have Lena Carlson in the room, who actually showed that what surgery is very good at is not only to make people lose weight, but to allow weight loss to be maintained in the long term. This is 20-year data, of course, from the JAMA paper. But I want to draw your attention to the standard errors of the mean over here at 1 year and how tight the standard errors are, and draw your attention to the standard errors over here, where the standard errors are much larger. Of course, the number of patients are smaller out here than out here, but what we are also seeing is the biology of the disease. We are seeing that some people respond to the treatment and others do not respond as well as we would like to think. And I certainly would like to challenge you in the audience to think of, if obesity is a disease, and we are treating it as a disease, why are we expecting any different outcomes to most of our other treatments? Because in whatever we do in medicine, we see this normal distribution, whether or not we treat blood pressure, or we treat dyslipidemia, or we treat hyperglycemia with our medications, we see that there are people that respond and don't respond. And here I'm showing you gastric bypass and sleeve gastrectomy, and I'm showing you this normal distribution. So I'll tell you my own biases before we start this meeting, but my own bias is that obesity is not only one disease, there's multiple diseases, and that we don't have any predictors that can tell me if a patient is going to respond or not respond. I don't have any biomarkers or any questionnaires that's going to tell me if this patient is going to end up losing 40% of their total weight or less than 10% of their total weight. And that is a real challenge that is very difficult for us. So I'm going to stop and maybe just ask Kelvin if you wouldn't mind introducing yourself and just explaining your own practice and your own views on this, and then Lee can go second.
Oh, okay. My name's Kelvin Higa. I'm a surgeon practicing in Fresno, California, and I started my career as the boy questioning the emperor. beginning in the early 90s, I asked the powers that be, how do our operations really work? And I was given the same answer. Well, it's restriction or malabsorption. And I thought, well, that doesn't make much sense to me, given that we make the same size pouch, the same size bypass, and that sort of thing on different individuals, but so be it. So not knowing how they work, then I asked the question, well, why do they fail? And that became an interest in revision or reoperative surgery to see if we could augment or take the patients that didn't do as well and make them better. And that was a very frustrating endeavor, as many as you know, because the common answer was, well, it must be all about compliance. The patient's just not complying. And we know that's not true either. And then now it's the big question is, well, why is there such variability in how our operations do to an individual patient? And can we target the right patient, the right operation, and using adjuvant medications and other things in order to get the patient to perform better rather than placing the blame back on the patient? And so this has been a quest to find all those answers. And I'm glad that you two are here to answer those things, because we as surgeons are not going to come up on ourselves.
Lee, and maybe you can share some of your experience and also how you came into the field and you know, so where your perspectives are now.
Yeah. So I'm Lee Kaplan. I came into the field as a gastroenterologist, although you didn't see me talking specifically about devices yesterday, because I really am more interested in the biology that underlies obesity and the way these operations work. And like Carl, I started in this corner of the field focusing my work on small rodent models that we developed for doing some of these operations. And it was very clear that surgery does not work the way the very, very smart surgeons who invented it thought it worked. It was a nice idea that restriction or malabsorption would be the operative principle. And when the operations worked back in the 50s, 60s, 70s, and 80s, it sort of reinforced the notion, well, if it works and we thought it worked a certain way, must be that it works in the way that we thought. The fact that it doesn't work in the way we originally thought is actually the best news for the patients. And I just want to leave you with that thought, that the best news for the patients is that these operations work physiologically rather than mechanically. And I'm not going to tell you why that's the best news for the patient until we get into the cases, but it is the best news for the patient. Now, Carl mentioned, if you could go back, Carl, to the SOS study, and I know Lena's here, but and you emphasized that gastric bypass and vertical banded gastroplasty, the key thing was the maintenance of the weight loss. What I'm going to say is, if the weight loss is physiological, there is no such thing as maintenance. Because if you change the physiology, the body has no reason to regain the weight. It's only when you fail to change the physiology adequately that the body is going to resist and try to regain the lost weight. So two things I want you to remember as we get started. One, that that surgery is physiological is great news. Hold that thought. And two, that it's because it's physiological that you don't regain the weight, not because surgery is doing something special to prevent weight regain. It's got a very special mechanism to lose weight in the first place. And with that, I'll turn it back to you, Carl.
So now what I'm going to do, just before we go to the cases, I think you've all been given a clicker, and we're going to go to one of the question slides. So this is just, if you wouldn't mind just telling us how many of you in the audience are surgeons. So click A if you're a surgeon, and click B if you're a non-surgeon. That just gives us a feel for the audience, etc.
C.
If you're really not sure, you can press C, but I suspect A and B will suffice. If we can see the results. Good. All right, so it's a nice mix. And I think that is the objective of this meeting. So when you walk out of this meeting, the reason why J&J really wanted to have this meeting is for us to think together, for surgeons and non-surgeons to think together about how can we solve these problems. So I think that's the principle. So if we can go back to the slides, please. So I'm going to start off with the first case, the first of two cases only. So this is a 45-year-old gentleman who had successful gastric bypass. You know him very well because he had a body mass index of 43 when he came to see your service. 1 year after the surgery, he had a body mass index of 29. And 3 years after the service, he still has a body mass index of 29. However, his hemoglobin A1C, because he had type 2 diabetes, pre-surgery was 9%. So he had good going diabetes. 1 year after the surgery, his hemoglobin A1C was 5.9% without any diabetes medications. And 3 years after the surgery, when he's maintained his weight, and in fairness, he's been compliant. He's always come back to you. There's no concern. He's sticking with the diet. He's doing everything that your dietitian would like. But 3 years after, his hemoglobin A1C has risen to 7.5 without any medication. So the first question, I'm going to put that to Calvin. What should we do now? So here we have somebody who had a good result, I think, we would suspect from a surgical point of view. Unfortunately, the diabetes has relapsed. What's our next step from your point of view? And I'm going to walk around with a roaming microphone, so please raise your hand, and I'm going to come to you first. So I'm just going to get Calvin's view first.
This is kind of an unusual patient for us. Usually we see the diabetes still in relative remission, and I'm going to put the question back to you guys, whether or not with an A1C of 5.9, that patient should have been taken off all their medications to begin with, because, we wonder if this patient should have been maintained on metformin or something like this. But from our standpoint, there's something is changing. Their weight's not changing. Maybe there's something different about the operation. We begin by, of course, doing the usual things, in back to the program, the nutritionist, dietitian, taking a history. But we're going to make sure this patient doesn't have a gastric fistula. Yeah. We'll do an upper GI series, make sure there's not a small fistula or anything else going on to explain some of this comeback. And then during this time, we're going to work with our endocrinologists, talk about maybe putting it back on some medications while we address this. Now, the problem is a BMI of 29 for most of our patients isn't good enough. Okay. And where we get caught up in as surgeons is that the patient will come in, my A1C is going up, but what about my weight? I really want to lose more weight. Okay. And perhaps we can address that at the same time, making sure that the anatomy is proper, but also adding some medications in order to lower the weight as well.
Thank you very much. If you wouldn't mind just saying who you are and where you're from.
I am from Bogota, Colombia. I am an endocrinologist, internist, and family practitioner. Obesity is a disease. So they have addiction to food. Therefore, you can put them fasting for 3 days and they stop the addiction. And then you need to give them a written diet, because you are talking about no physiological thing. Surgery is not physiological because you cut the stomach. So I have patients that had surgery, and they have 45, the mass index very high, and they came down. They have fasting glucose, normal fasting glucose, because you have a very little food at night, and they go urinate. So fasting glucose, you cannot do it, because they are normal after surgery. Hemoglobin A1C, you cannot do it, because hemoglobin A1C shows hyperglycemia in fasting, hypoglycemia, and they have normal fasting. This person has still diabetes, and they all have diabetes after surgery, because you don't measure postprandial hyperglycemia, and they love to have food that is sweet. So I have somebody that came to my office, 3 donuts.
I'm just going to stop you there. So I'm just going to take draws with you. So thank you very much. We're going to come back to that, because I want to take you up on that point about the physiology. We're going to take, but Draw, I'm just going to ask you. So,
okay, good morning.
You just say again who you are and where you're from.
Dicker, Israel. I'm head of internal medicine and obesity clinic. in order to have a successful relapse, a successful remission, you should control the pre-surgery hemoglobin A1C, meaning that we wouldn't operate such a patient. We would treat the hemoglobin A1C to reduce it to around 7.5 before the operation.
Okay.
And we showed that this is the main factor for success. Also, Aaron Wiskovsky showed this issue that in order to prevent or in order to have a successful remission, you should concentrate on pre-surgery hemoglobin A1C.
Okay.
The second thing that I want to say that in this patient we are giving them metformin. We should remember that metformin after the operation had 50% more effect. And because we are giving metformin for patients with prediabetes, so this patient 1 year after the operation is pre-diabetic patient, and he should entitled to get metformin in order to prevent the relapse of diabetes.
Okay, so maybe if we can get a voting slide up. So if you wouldn't mind, so Dror has pointed out that what they would do in their service is they would reduce the hemoglobin A1C before surgery. So if you would sort of just press, would you in your service go to the effort of taking somebody with a hemoglobin A1C of 9 and prevent them from having surgery, delay the surgery by a certain number of months, 3 months, 6 months, whatever the delay is, and try to medically reduce the hemoglobin A1C before you have surgery. So if you do that, press yes. And if you would take the patient with a hemoglobin A1C of 9 and progress to surgery as quick as you can within your system, press no. So if you wouldn't mind voting on that. That's a good point, Ro. So if we can see the results. Okay, so we see a split there with the majority of the people in the room moving forward for surgery straightforward.
You should ask who is no.
Yeah, but I think that's a sort of an evolving idea, and I know there's controversial data. There's data to show that it works, and there's data to show that it doesn't work much. So we need to understand that better. Good. The second point that Dror has pointed out is that I think that answers our question. If we can go back to the next one, which was what would you have done at 1 year? Could we have done anything earlier? And he mentioned that some of his patients, or most of his patients, remain on metformin. And we're going to come back to that. But I'm going to ask Almino first. Almino, if you wouldn't mind just saying who you are, where you're from, because people don't know you really.
Yes.
And then you can say what you would do.
Almino Ramos from Sao Paulo, Brazil. Karel, look, I think that this case is a proof that we have to review our concepts about what we qualify as success in bariatric surgery. Because if we take the result at the first year, that's the good news. If you go for 3 years, that's the bad news, because we have a patient with from 43 to 29, so this patient lost 30% of the total weight in 1 year. But after that, we have a plateau, and the patient has 3 years after 29, and probably we will start to have some weight regain. So by the guidelines we have right now, if we consider 50% excess weight loss as success, this will be a success. But the patient is about to start to regain some weight, and in terms of diabetes, the patient is starting to be not so good controlled. So I remember I saw you about 2 or 3 years ago saying that in a case like this, maybe we should not remove metformin from the patient since the beginning. So what do we do with these patients? No matter the patient is good, we keep the patient on metformin. We removed metformin just if we have some problem and the patient start to have some hypoglycemia. But on the contrary, we keep, and I think that when we keep, we can avoid situations like this. But right now, I think that it's time to put the patient back on track, to start to use some drug, probably metformin, and to advise the patient that we have to have this patient closer in more intensive multidisciplinary counseling.
Good. So if we can maybe just go to a voting slide, because Almino made the point there of maybe starting medication at this point. So if you wouldn't mind going to your voting pads and say, at this point, the patient has a hemoglobin A1C of 7.5, which is, and I'm going to come to Professor Poris in a minute and ask him about whether or not we're just beating ourselves up. Remember, this PP person started with a hemoglobin A1C of 9. And even 3 years afterwards, we've made a massive improvement in the glycemic controls, come down to 7.5. So we've done this patient a massive service. So are we just beating ourselves up for nothing? But let's go to the question. The question would be, at this point with the hemoglobin A1C of 7.5, in this patient who's not taking any medication for their diabetes, would you reinstigate medication for diabetes, yes or no? Okay. You can press your button. I'm going to come to you now, Carlos. So if we can see the results of that. All right. So most people would say that it is maybe a good idea to start medication. But if I can ask Professor Boris to say, are we over-egging it? We have done this patient a massive service. We've taken the hemoglobin A1C of 9, which is very poor control. And say even if we instigated draws protocols and this patient had a hemoglobin A1C of 11 and we brought it down to 9, we have done this patient a great service. Are we beating ourselves up, or should we strive for even better?
Thank you. First of all, I think this guy is a success. But secondly, there are several things. The first one is he should have been operated on earlier, and the chances are that he might have had a better success. Secondly, I think exercise and diet are overlooked, and exercise is particularly overlooked. It does work. We do a lot of studies on exercise, and it's remarkable how effective it can be, and patients have to be monitored about that. And then, by the way, I'd also repeat the study. Okay? But otherwise, I think metformin is the next good step.
Yeah. And also, of course, exercise can also be viewed as a medication. So I'm just going to, you've had your hand up.
Yeah, thank you. My name's Larry Hirsch. I'm a diabetologist, and I think we have to avoid the sort of reflex to treat the A1C, because I don't know what we're treating at this point. Assuming that there aren't anatomic abnormalities that have arisen, I would want to know what this patient's beta cell function is before I throw them back on an anti-diabetic medication. Not very complicated to measure his fasting C-peptide and or insulin, and perhaps try to assess whether there's a degree of insulin resistance, and then I would choose a medication. The data are very clear that when somebody develops type 2 diabetes, they've lost somewhere between 50 to 70% of their beta cell function. He had an A1C of 9%, we don't know for how many years, and presumably his beta cell function is significantly impaired. So I might be inclined to, depending on the results, to use a GLP-1 or an SGLT2 inhibitor, and not just simply jump to put them back on metformin.
Okay, so there's more options, and I think that's also what we know now, is that we are not limited in the same way as we have more than one option when it comes to surgical treatments. We have more than one option when it comes to medical treatments, and of course, I would argue that really to potentiate it, we need to put these things together and understand how to put it together. I'm going to come back, but I'm going to ask Lee Kaplan first, and then I'm going to go to Calvin. Lee, so you've really pioneered this idea of the heterogeneity of obesity. But of course, our diabetology colleagues, have been driving the same concept. Type 2 diabetes is not one disease. Left groups, in Lund has sort of shown, there's at least 5 clusters, of type 2 diabetes. And the people that we mostly see in our bariatric services are people with so-called morbid obesity diabetes, which are the ones that generally end up with the fewest complications. But those other patients, as outlined before, with severe insulin-resistant diabetes, they're the ones that develop the complications. So maybe just from your perspective, we've been treating obesity as one disease. We've been treating type 2 diabetes as one disease, but where's the thinking in this now, when it comes to the heterogeneity of both of these conditions?
Well, so when you look at the slide that you showed about weight loss, you see heterogeneity. But that's what an epidemiologist looks at. They look at thousands of patients and they see, if you can get to that slide,
yeah.
You see that there's a distribution of response. Now, this distribution of response is a weight loss response, but you could have a distribution of response in terms of a diabetes improvement response. But that's not how we as clinicians see patients. We don't see a distribution. We see one patient in front of us who gets a certain response. And so if you look at it from the patient perspective, the individual patient perspective, they are somewhere on this curve. Each patient is somewhere on these curves. And the question really becomes, what do you do when the response is less than perfect? I agree with Walter. This story is a success story. And the only reason you would consider it a failure story is if your expectations are misdirected, which is you expect magic and perfection every time you operate on a patient. These graphs show that you can't get magic and perfection because the human body is not designed for magic and perfection. So when you have what you would consider a response that could be made better, the real question is, how do you make it better? And this is where the physiology of these operations come in. Think of the operations as treating with a drug. If you were treating with a drug, whether it be metformin, or you were treating with an SGLT2 inhibitor or a GLP-1 agonist, as was suggested, and it didn't work as well as you wanted, you would complement that treatment with another treatment, whether it be exercise or a change in diet or a second drug. So if you think of surgery as a super powerful drug, which is what it means to be a physiological intervention, then the logical thing to do when somebody is not getting a complete response is to complement that. If surgery were mechanical, as many people used to think, as I used to think, then there would be no potential for synergy between surgery and a physiological intervention. That's why it's good news that it's physiological, because there's that opportunity for synergy. If you have somebody who has diabetes because they have three things partially wrong, they have a component of insulin resistance, they have a component of hepatic insulin resistance, they have a component of beta cell failure. If that's the case, then if surgery incompletely resolves those pathophysiological events, you have the opportunity to complement surgery by lifestyle or by drug and end up with a synergistic benefit between surgery and those other interventions. And I think what you have to look at in individual patients is, as you watch your own patients, to see, did something that didn't work very well before surgery work much better after surgery? Somebody's already made the comment that metformin sometimes works much better after surgery than before surgery. Why is that? That's the synergy I'm talking about.
Okay. Calvin, you had a comment. Do you want to add to that?
The question I have is really, what is the optimal metric to determine diabetes after a bypass? We know that the variation of sugars are much more. I just don't know that the validity of an A1C after gastric bypass has the same implications as before bypass, and it could be, either way. Maybe it should be tighter or looser, depending. And I don't know if anyone has some research or thoughts on this.
What is our targets? And I think there's a discussion today specifically about, how do we define remission? Should we even define remission? And, where do we want to go? So,
Carl, can I just ask the audience, if I might,
please,
if anybody has experience? One of the evolving areas in diabetes management is use of continuous glucose monitoring. And it's still, as best as I read it, up in the air as to when you look at different patterns of tracings of continuous glucose monitoring, which are the best ones? What's the goal? So what I want to know from, if anybody has experience, to get a sense of how different does it look when you use CGM after bariatric surgery, and do we yet have enough information to have a sense of whether CGM tracings could be used to help define what is the best approach we might want to take?
So you just introduce yourself, and then also just one sentence on what it is, just so that everybody is on the same page about what
so my name is
glucose
Joseph Vidal.
monitoring is.
I'm an endocrinologist from Spain. And CGM is a method to monitor glucose continuously. So we use that following SG and gastric bypass in patients that were in remission of diabetes. So that was maybe 3 years after the surgery. And the pattern was totally different. Those after sleeve gastrectomy had a very flat pattern, so very little waves, whereas those after gastric bypass were 25% of the time in hypoglycemia or in hyperglycemia. So that was especially postprandially. They were in hyperglycemia, and 25% of the time were in hypoglycemia. So if hemoglobin A1C is meant to be a mean of plasma glucose, one may argue it says something different after a sleeve gastrectomy, where it would reflect more the normal situation, the physiological, the non-surgical situation, as compared to the gastric bypass, where it would be probably lower than it should probably be. So, or at least it's not reflecting mean values, but waving values.
Okay. Can we use the, just a quick follow-up question, can we use the CGM to help guide the nature or the specific medications we would use in a situation like this?
So let's go to a question page. So I'm going to ask the audience, who think that, and it's an experimental tool but now it's coming into clinical practice more and more, especially in type 1 diabetes, but who think that we should rather use continuous glucose monitoring as opposed to hemoglobin A1C? So vote yes if you think continuous glucose monitoring is better, and vote no if you would rather stick with our usual parameters such as hemoglobin A1C that of course most of our epidemiology is based on. Remember, we don't know what the continuous glucose monitoring should be like, but of course we need to find that out. So if you vote now yes for CGM, no if you don't think that CGM should be used. So if we can show the results. Okay, so a split of opinion, and I think this is what this Meet the Expert session is about. This is not us telling you what to do, it's you telling all of us in the room what are the questions, what are the problems that we struggle with, and where are the things that we need to improve on continuously. I'm going to go to Lena Carlson first, who's had a question for a while ago. And maybe you just want to share your the SOS data for pre-diabetes and what the benefits of actually operating on people with pre-diabetes and not even waiting until they develop diabetes.
I think it's you have very strong effects in pre-diabetes, and I will talk about that later today. But I think even in patients with diabetes, you have much better effect if you treat early. Newly discovered type 2 diabetes, then you get prolonged remission, and you also prevent the microvascular complications to a greater extent compared to if you have somebody with long duration.
Okay, so let's do a question slide, please. This sounds like a stupid question, but it's going to lead us into the next case. So the question now is, who think that we should operate on diabetes earlier? Okay, vote yes, wait, just wait before you vote. Or who think that we should wait until diabetes cannot be controlled with our medications and then operate on the patient? So you vote yes if you think vote surgery as early as possible for people with diabetes. Vote no if you think people should only have surgery if the medication cannot control their diabetes, if you wouldn't mind doing that. Carlos, I'm going to come to you now. If we can see the results, please. All right, so we have an overwhelming majority of people saying that we should operate on people as early as possible. Carlos, you had a question earlier.
Carlos Kevon from São Paulo, Brazil. What I see in my practice that many patients are refractory to use medications after surgery because they thought before surgery that they are going to get rid of medications. And how you manage this? Because many times they don't want to have medications for diabetes or for losing weight, more weight.
Okay. So, Carlos, you published the first randomized controlled trial specifically looking at people with hypertension, right? And you showed in your randomized controlled trial that surgery was much better than medication when it comes to treating hypertension. That was really a breakthrough paper in Circulation, etc. But hypertension is not one disease. Right? There's many different diseases that causes hypertension. So are we able to investigate hypertension and decide which patients should have surgery or which should not? Or are we not there yet when it comes to biomarkers?
No, we should operate patients with essential hypertension, for sure. Or patients who has sleep apnea.
Sure.
Because there is a relation with obesity, and it's not essential, but it's due to the sleep apnea. Other types of hypertension probably is not going to work, the surgery.
So I think the point I was trying to make there is that most of the chronic diseases that we are treating, have heterogeneity. Hypertension is not one disease. Obesity is not one disease. Type 2 diabetes is not one disease. And therefore, when we use one treatment, such as a standard gastric bypass or a standard sleeve gastrectomy, it should not surprise us that we have different outcomes when it comes to those approaches. Good. But I'm going to move on.
Carl.
Yes, Lee.
Could I ask your indulgence before you go to the next case?
Sure.
Could we ask one more question? Could I ask one question?
Please.
Could we get the question page up here? And the question I would like to ask for this patient, we'll come back, is this patient now has a BMI of 29, has maintained the BMI of 29 now for 3 years. We were talking about the diabetes, but the question I have is, today, 3 years later, does this patient have obesity? Yes, no, or you don't know?
Good. So the question is clear. Do you want to rephrase the question again? I think it was pretty clear, but just rephrase it again because
the question is, if you go back to the slide, please. Go back to the patient slide, please. Can we do that? No, I guess we can't.
Yeah.
This patient has had a BMI of 43, now has a BMI of 29, has maintained 29 for 3 years. The question is, today, at a BMI of 29, does this patient have obesity? Yes, no, or you don't know?
Okay, so if we can go to, please vote now. Okay, if we can see the outcome. Okay, so interesting. Lee, do you want to address that?
So the reason I asked the question, even though this is a diabetes session, is because if obesity is a disease, which means it has a pathophysiological basis somewhere in there, then the answer has to be yes. Because if you have a disease, the way we define disease, chronic non-communicable disease, is you don't cure it. And so if I ask the question differently, does this patient still have diabetes? Almost everybody in the room would say yes, because you saw the hemoglobin A1C slipping back up again. But in obesity, we frequently say that it's a disease, but as soon as the BMI gets below 30 or whatever your target number is, you stop thinking of it as a disease. So for the 40% of people who said it's not a disease, we would argue against that point, because whatever the pathophysiology in that patient that caused them to be heavy in the first place hasn't disappeared. It's just been controlled by the physiological effect of the surgery. And so if we think about obesity, the way we think about diabetes, the way we think about hypertension, the way we think about sleep apnea, that's how we have to be consistent. So for those of us who are arguing all the time that obesity is a disease, we have to think of what that means. And we have to then be consistent in our modeling to recognize, like every other non-communicable chronic metabolic disease, it doesn't go away when you lose weight. It just is controlled when you lose weight.
And that does not make the intervention less successful. It makes the intervention more palatable and agreeable for people to use. And I think that's what, again, this session is about, is how can we make surgery part of the treatment algorithms for non-surgeons? And part of that is understanding that what we are treating is a real disease and that surgery is a real treatment that works through physiological basis. But let me challenge you now with the next case. So here's another controversial case. So this is, and this follows on from Lena's point that she's made before. So here we have a 58-year-old lady who is very compliant and very interested in having a gastric bypass. So you do not have to convince her. She wants to have an operation. Right? She has a BMI of 38. She has a hemoglobin A1C of 10.5, despite seeing Dror, and he has tried to do everything that he can, and this is the best that we can do for her. But her blood pressure is very well controlled, and her dyslipidemia is very well controlled. 2 at 2 millimoles per liter, remind me, that's about 100 milligrams per deciliter, or 86 milligrams per deciliter. So this is really good control. So really excellent medical treatment so far. Diabetes for 12 years, diabetic kidney disease with renal function that has declined and now only 45 milliliters per minute, and albuminuria, good going albuminuria. No myocardial infarction, but she had coronary stents for angina 3 years ago. She's on optimal medication, including metformin, liraglutide, canagliflozin. She's on Lantus, long-acting insulin. She's on atorvastatin, perindopril, and aspirin. So what should we offer her? So Mufi, if I ask you, well, first let me go to Calvin. Calvin, what do you think about this patient as one of the experts in the room? The question is, are the operative risks too high, and what are we going to do? Have we missed the boat? Should we just treat this patient palliatively?
Yeah, I think so. This patient is obviously a relatively moderate to high risk patient, stage 3 renal disease. And all the comments that were made here already, I would agree with. I would optimize the diabetes, optimize all the medical problems, see if we can get better diabetic control, glycemic control prior to taking this patient in. I consider this patient an operative candidate because of the severity. Wondering, as Walter is, why didn't we see this patient before? And if she's such an advocate for having surgery, why didn't we see this patient 10 years before when we would really have an impact on this patient's, disease process, longevity, etc.
But have we gone beyond the point of no return? So when we operate on this patient, are we in fact just exposing the patient to risk, or does this patient stand to benefit any?
So this patient would necessarily in our system would have a complete evaluation, workup, cardiovascular, everything, provocative tests and et cetera. And on the whole, most of the time this type of patient it's a fairly common patient we see. I would not consider this patient in a center that has experience, that has, it's not an outpatient clinic, but a full-on program with all the bells and whistles. I would not consider this patient too high risk for most centers of excellence. But the secondary question is, if we're going to offer this patient surgical intervention, what might that be?
Right. And we're going to get to that. But I want to get to this question about should we operate, yes or no. And the reason why I'm specifically putting this to you is that we have all been, I think, in agreement that the earlier we can use surgery, the more benefit we may have. Right? I think that all the data, the SOS is very clear on that. However, despite 12 randomized controlled trials being published in the highest impact factor papers, there has been no change in the number of people with diabetes having surgery. Okay? And part of that, in my opinion, and I'm throwing it up to you to discussion, Mufti, I'm going to ask you for your opinion now, is that part of it is we've been proposing a solution to diabetologists for something that they did not have a problem with. Most people with most diabetologists don't have a concern with somebody with very early diagnosed diabetes that they can control with metformin and maybe with really good drugs like GLP-1 and SGLT2s. But this patient really troubles your average diabetologist because despite their best efforts, you can see they've been really well treated because you can judge it from their blood pressure and their lipids. This patient is very difficult. But now very often what we hear is that we should not operate on these patients. These are not optimal candidates for surgery because we may not put them into remission. So we are not offering a solution to the diabetologist when they really have a problem. So if maybe you can comment on that. What has happened in your practice, and is this the type of patient that the diabetologists bug you about, or do they actually want you to operate on people that were diagnosed yesterday on metformin?
I completely agree with what Kelvin is saying. We don't get the early diabetics. We don't get the first bite on the cherry. So we get this on a regular basis. Now, I would back my endocrinologist, my diabetologist, and say he's done the best job or she's done the best job, and probably 10.5 is not acceptable. We do know that this eGFR is going to increase, the albuminuria is going to increase in progress. Now I have to be critical of myself. Can I offer remission of diabetes to this patient? Maybe no. And that's the conversation me and my endocrinologist have to have with this patient. Can my endocrinologist better control this patient post-surgery? Yes, that's a given. Can I prevent this stage 2 or stage 3 renal damage from progressing rapidly, or can I slow down the progress? Yes, with surgery. So I think this is an ideal candidate for surgery, given all the factors that you've given. I do know that post-surgery, this entire list of medications will crash down, will come down. I think I will have a better acceptable diabetes risk with this patient, so I would offer surgery.
Okay. I'm going to come back to, I'm just going to ask Michael Suter first. So, Michael, we have been very enthusiastic, and rightly so, because surgery is so incredibly powerful. And, you know, even the American Diabetes Association didn't have a definition for remission until they actually took surgery seriously. But in our quest to achieve remission for all patients, have we done ourselves a disservice in making clear that a patient like this, who is surgically high risk but medically much higher risk, could really benefit from our treatment? So should we say that remission is not the ultimate goal? Making this patient live longer with a better quality of life is the ultimate goal.
Well, I totally agree with what has been said. And as the typical patient, we get too. We don't get the early diabetics either. But I think we should aim for better control rather than remission. And whether we use surgery alone or in combination with medication, I don't really care. The ultimate goal is to control the disease as good as we can in order to prevent complications. Okay. And I think that should be our ultimate goal. And the more patients we can control, and if we bring the A1C down by 2 or 3 units, it's going to have an impact on the overall survival and renal function, etc.
Okay. Now, this is, as Calvin pointed out, this is not a patient to be taken on lightly. This patient has multiple comorbidities as a cardiometabolic patient, and surgically this patient will be of higher risk than somebody that was diagnosed yesterday with diabetes. So my question is, if we can go to the question slide, should we advocate, should we go and ask our diabetologists to send us these difficult patients? Or in fact, if we ask them to send us these difficult patients and we get a higher surgical mortality rate than we have now, because remember, surgical mortality rate is incredibly low because surgery is so good and people are being worked up. But if we start operating on thousands of these patients, by default, we're going to have a higher surgical mortality rate. So my question is, that's the yin and the yang. My question is, should we advocate for those difficult to control people with diabetes who is very high risk to have surgery, or should we rather not say anything, treat them the best we can when they get sent? So the question, so just A, we should ask for these patients, or B, we should just do what we do at the moment and not advocate specifically for these high-risk patients. So vote now, yes or no. Yes, if we should go and find these people to have surgery, or no, if we should just do what we do and not actively get these patients into services. So if we can vote now and show, if we can show the result. I'm going to go to the questions now, but I'm just going to ask Lee. Okay, so you guys, this is the brave room. You all took your bravery pills this morning, right? So you so Mufti has just said beggars can't be choosers. You know, we haven't really moved the needle when it comes to a number of patients. So Lee, if we go back to the patient slide, is this not beyond the point of no return, or should we really be advocating for these patients? Because this patient, of course, has NASH as well. Nobody has just looked at the liver, right?
So the real question in taking care of any patient who walks in our office is, do we have an intervention that will change the course of their life in a way that makes it more likely that they'll live better or live longer? That's the question. That's the question when we see them on the medical side. That's the question when you see them on the surgical side. That's the question for that patient. And we don't have data yet on average to say that operating earlier or operating later will give a differential response to life expectancy, will give a differential response to micro or macrovascular disease, heart disease. We don't have those data. What we have is we have data that show people do well when you operate early. That's true. You'll get more remission when you operate early. But remember, if you take one patient and you operate today versus operating in 10 years, they've already lived 10 more years by the time you operate. So you don't expect them to live the same length when you operate late. So the question always is, for this patient walking in your office, what is the risk-benefit ratio in your estimation for that patient? So I'm delighted to see people say they will operate on these more difficult patients, because these more difficult patients are more likely to benefit to a greater extent immediately from the operation, so long as they're not so sick that you're going to kill them in the process. And that doesn't happen very often. With a 0.1, 0.2% mortality, even the sicker patients are still going to have a very good chance of surviving the perioperative period and benefiting tremendously. So as a non-surgeon, I would be a strong advocate for the surgical community to work well with their anesthesiologists, with the endocrinologists, to optimize the benefit immediately, the survival benefit of after surgery, so that the patients can then get the long-term benefit, which I have no doubt is going to be tremendous if you get through that original period.
So 2 more comments, and we will finish on time. So 2 short comments.
Okay. This is a classical patient treated badly by the doctor that doesn't know how to treat the disease. You need to take all these medications out. The only treatment she needs to have is fast glucose and have a glucometer to check every time she eats. She ate wrong, therefore she needs to inject so many units of insulin to put the glucose normal all day. No oral medication put glucose normal all day. Okay. So she needs to be written what to eat, and that's doctor's fault.
Okay. So
Surendra Ugale from India. Firstly, I do a fasting and stimulated serum insulin and C-peptide for this patient. Then I'd apply a scoring system, whichever of the 4 scoring systems you want to apply. And you'd realize, looking at the history, that the patient would fall in the group of diabetes that is very severe. So you know from the initial state that you are not really going to get a remission, but only an improvement, so at least you can let the patient know beforehand. Next, I would convince the patient, based on all data and past experience, that a bypass is not going to solve her problem in a situation like this. So if the C-peptides and insulins are favorable, I would do a procedure like an ileal interposition with a sleeve which We see often patients like this, and they do well with this. If those levels are poor, then I just offer a sleeve to improve the status and make it easier for the control of diabetes.
Thank you. So I think we're just wrapping up now. We have 2 minutes to wrap up. But I think this has been a really helpful session to me, and thank you for you as the experts in joining this session to explore these challenges that we have clinically, because we have a lot to do still. And maybe, Calvin, if I can ask you to wrap up and Lee to wrap up in 1 minute each, just where you think the future lies and where we have to help. You know, this conference is all about implementation. So how can we help by working together, surgeons and non-surgeons, to really implement better treatments for our patients? So maybe Calvin and then Lee.
Well, I think that your final statement says it all. You know, it's not, and it's really not just working together. It really is the synergy that we bring to the optimal care of a given patient. Because so much as surgeons, we're looking in isolation. We have the messaging wrong. The reason the patient comes and disappointed because they didn't lose enough weight and they want more surgery and they want pills, because oftentimes the messaging from the surgical camp is we can cure everything, and that's obviously not true. And we're not going to put everybody in remission because of the heterogeneity and that sort of thing. And so the patients have to understand that it's a cohesive effort, and it'll be that type of relationship between, say, the oncologist and the oncologic surgeon that's going to get us the best care. And then that can only be done when we really work together and understand what's better for the patient as an individual, which is Lee pointed out very well, that every patient has to be treated as an individual, not just a statistic.
Okay. Lee?
Yeah. I completely agree with what almost everybody here has said. Probably the future, and Kelvin just said it, and I think it's an important point. The future is to do studies and to contemplate how we approach individual patients after those studies are done that look carefully at pathways of therapy. We've been spending time, which you have to do, to figure out how good the therapies are, whether a particular operation is good for a particular patient, a particular timing is good for a particular patient. It's a little bit like developing combination therapies with drugs. You have to study the drugs individually, and then you study them in various combinations. I think now that we recognize that surgery is very effective, we have to start looking at pathways of care and studying them carefully. Those pathways of care developed from careful observation of individual patients followed by good clinical trials. We're at the stage now, I believe, where we have to look at a comprehensive approach to care that includes lifestyle, pharmacotherapy, and surgery, and figure out for which patients, which therapies, and in what order. And those are the studies to be done in the future.
Well, I wanted to thank you for coming and contributing to this conference. Thank you to J&J for the sponsorship, and enjoy the rest of the meeting. Thank you very much.
Gwen.